Everyone, and a very warm welcome to this special session bringing the highlights of the newly released ESC 2025 Valvular Heart Disease Guidelines, fresh from the recently concluded ESC Congress held in Madrid. We are truly privileged today to have with us two outstanding experts who will guide us through an exciting and practice-changing area in cardiology. From Leipzig, Germany, we have Professor Michael Borger, Director of Cardiac Surgery at the Leipzig Heart Center and professor at the University of Leipzig. He has played a pivotal role in advancing the management of valvular heart disease globally and will be bringing us the very latest highlights from the new ESC 2025 guidelines. We are also delighted to be joined by Dr. Tiny Nair, Chief Cardiologist at PRS Hospital, Thiruvananthapuram, India, a leading clinician and educator who has been at the forefront of shaping cardiovascular practice in our region. Together, they will share their insights that bridge cutting-edge science and day-to-day patient care. Dr. Nair, over to you, sir, to kindly guide us through the session.
Thank you, Manjusha, for that introduction. I think this is a very important session because a little while ago we were discussing pharma doesn't get involved generally in good academic sessions that involve valvular heart disease, right? They do sessions on newer therapies, they do sessions on hypertension, diabetes, and ischemic heart disease, but not generally on a topic which is so very important like valvular heart disease. The scenario of valvular heart disease in India has been tremendously changing. I think that change is something like no other subspecialty in cardiology has seen. When I was a student at the medical school 3 decades earlier, our main chunk of clinical material would be rheumatic heart disease, mitral stenosis, mitral regurgitation, aortic valve disease of several kinds, pulmonary hypertension, organic tricuspid valve disease. We have seen all of them, and they would be the main clinical material that we would see. So therapies were targeted at treating them. But look at the clinical scenario now. In the last 3 decades, it has transformed to where we are seeing huge number of degenerative valve disease, both aortic and mitral valve disease. And that's the reason why you see so much of rise of interventions in degenerative valve disease like the TAVI and the TEER done in most major cardiac centers. Ischemic heart disease is another area where valvular regurgitations has come up, whereby we are talking about associated mitral valve repairs, mitral replacements, and various other modalities of intervention. Right. This year, the ESC, we had seen the new guideline being presented, and that was truly, I think, a game changer. Almost every parameter we looked at TAVR. In TAVI, we saw that there is so much of change in the age of guidance, age of interference, comorbidities, the NOACs that we use, the antiplatelets that we use, everything has changed. Look at TER. It has been totally changed now, looking at ventricular and atrial etiologies, totally different. So I think in that background, we have so much to learn, and who else other than Professor Bogus can highlight and talk about and teach us about the changes in the new guideline and what we should take home for our practice in India right there from tomorrow morning. Over to you, Professor Bogus.
Thank you very much, Dr. Nair, for the kind introduction and for the invitation to speak today. And I'm just sharing my screen now. On the 2025 ESC EACTS guidelines on management of valvular heart disease that were presented last weekend in Madrid by Fabian Prats, an interventional cardiologist from Bern, and myself, a cardiac surgeon who was the appointee of the EACTS. Just as a quick recap, I'm sure everybody already knows this, but Class 1 are those therapies that are recommended. Class 2A are therapies that should be considered. 2B may be considered, and 3 are not recommended. And then the levels of evidence, level A is multiple randomized trials, randomized clinical trials or meta-analyses. B is a single randomized clinical trial or large non-randomized studies. And C is expert opinion only. So this was an update of the last version of the guidelines, which was in 2021. And because this is such a dynamic area, like Dr. Nair was saying, the ESC felt the need to come up with a new set of guidelines. And it's also important to note that we had two patient representatives, one from the ESC and one from the EACTS, that were on the task force and also had a lot of input into the guidelines. And as you can see from the central figure on the right, we've tried to stress the fact that patients' preferences and goals should always be taken into consideration when coming up with the shared treatment decision. We have 28 new recommendations and 50 revised recommendations in comparison to the 2021 version. And we have brand new sections on valvular heart disease in patients that have undergone cancer or radiation therapy, cardiogenic shock and acute heart failure. We expanded the multiple and mixed valvular heart disease section of the previous document substantially. And there are also two new sections on sex-specific considerations and pregnancy. So one of the concepts that we really tried to stress is the heart valve center in the clinic. The heart team is not a new concept, but the heart valve center, we're really trying to stress that heart teams in referral centers should be part of a network that's in regular communication with these larger heart valve centers where even more disciplines are able to be involved in the patient's care. And as a absolute requirement for these reference heart valve centers is that a cardiac surgery and an interventional cardiology team are on site and available 24/7. And in these heart valve centers, we think that these are the best places to handle complex patients because of the high procedural volumes at these centers. And the complex patients and the complex procedures that they require are listed within the document. And I encourage you to look at these in detail. These were the types of patients that we suggest referral to the heart valve centers because of the relationship that has been shown consistently through multiple publications that there is a volume outcome relationship. We also stressed the essential role of multimodality imaging, not just transthoracic echo, but of course transesophageal echo, and the increasing role being played by CT and CMR. All of these modalities are required in order to determine the severity of the valvular lesion, the mechanism, the etiology, and as well to determine how much cardiac damages are present. And those are all important aspects that need to be taken into consideration. For example, on the right here, the patients with AR, here's a figure of the imaging algorithm that should be used for these patients. And there's one of these figures for every major valvular pathology. When we talk about CT, we also made considerable changes to the previous version in that we increased a previously 2A recommendation to a 1B recommendation that cardiac CT angiography is recommended for patients that have moderate or less pretest likelihood of obstructive coronary artery disease in order to rule out coronary artery disease. I know that this is not standard of care in a lot of centers, but at our center in Leipzig, we've already switched to this a few years ago. And patients that really have low pretest likelihood just need a CT and do not need invasive coronary angiography, which of course in the discharge study from 2022 was shown to be associated with higher complication rates and no better cardiovascular outcomes than cardiac CT. We also said that if patient is undergoing TAVI and it's a good quality cardiac CT that rules out significant coronary artery disease, that's okay. You can proceed without angiography as a 2A recommendation. And in response to the Notion 3 trial, we said that those patients scheduled for TAVI who have more than 90% stenosis in a large coronary artery, that a 2A recommendation for PCI to be performed in such patients. With regards to aortic regurgitation, as I said before, we look at several aspects of the lesion, and in particular, the qualitative, semi-quantitative, and quantitative assessment of the severity of the AR, because this can be quite challenging for this disease. And CMR can be particularly helpful for patients, especially with eccentric jets, in order to quantify the regurgitant fraction. As far as indications for intervention go in patients with aortic regurgitation, the first step that should be taken is to see if they have significant aortic root enlargement, because of that can, of course, in and of itself be the reason for the aortic regurgitation. Then we want to assess the severity of the AR and whether or not the patients have symptoms. If there are any signs of left ventricular damage, so left ventricular dilatation or decreased EF, then we recommend surgery as a class 1 recommendation, regardless of whether or not the patients have any symptoms. And then we use a bit smaller cutoffs, which is particularly relevant, and I think in Indian patients for smaller women, because you have to be indexed to the body size before, so that you don't wait too long in the disease process before recommending surgery. And so we said this was a 2B recommendation for surgery at these smaller LV dimensions. If the patient has significant aortic root enlargement, we said, please follow the 2024 ESC guidelines on aortic aneurysmal disease. And if they have some AR as well, if the AR is minimal and there's good tissue quality, then we would say the patient should undergo a valve-sparing aortic root replacement, so a David operation. If the tissue quality is not good, or if the team does not have a lot of experience with the David operation, then we said a Bentall procedure is also a reasonable option. We also have this new 2B recommendation, as I said, at smaller dimensions that are indexed to the body surface area, particularly relevant for smaller women. And a volume, this is a volume cutoff based based on either echocardiography or cardiac MRI. We also said that there's increasing evidence that in centers that have experience, that an aortic valve repair can be considered as a 2A recommendation when durable results are expected. And then as a brand new recommendation, for the first time, TAVI is mentioned for AR if the patient is high risk for surgery. So this is a 2B recommendation. And this was based on the Align AR, which was using the Jena valve TAVI, which is particularly suitable for AR. But as I said, this is just for patients that are not considered surgical candidates. And you see good results with the Align AR, although the new pacemaker rate was relevant at 24%. Aortic stenosis is the next valvular lesion to discuss, and this is similar to a previous image that figure that we had for these patients, where you assess the mean gradient and the maximum velocity across the valve. You assess the aortic valve area. Stroke volume is then the next thing that needs to be taken into consideration, which plays an important role. And then the left ventricular ejection fraction. This is for patients with low gradient. So if they have a high gradient, then that's the other side of the equation. But if they have a low gradient, then it's important to determine, is it normal output or low output? And if it's low output, then we said for the first time that CT scoring of the aortic valve calcium is basically at the same level as dobutamine stress echo. Before, dobutamine stress echo used to come before CT scoring, but it's been subsequently shown that dobutamine stress echo to identify those patients with reserve with myocardial contractile reserve doesn't really matter, because the patients also without reserve profit from an intervention, as long as there really is aortic stenosis present, and that can be confirmed with the aortic valve calcium scoring. So in response to the early TAVR trial, we also slightly modified the recommendations for asymptomatic aortic stenosis. Of course, patients with LV dysfunction, less than 50% ejection fraction, is a 1B recommendation at the top of this table, and that stays the same. But we now have a 2A recommendation saying that if a patient has asymptomatic and severe aortic stenosis, that intervention can be considered, that being either TAVI or SAVR, if the procedural risk is low, as an alternative to close active surveillance. This may be particularly relevant in India, where you may not always be sure that the patient is going to come back for a control appointment and to recheck their aortic stenosis and their clinical status. And you may want to consider, therefore, intervening before they get lost in the system. And this was based on mostly two new studies, the early TAVR study and the EVOLVE study. Early TAVR showed a benefit with regards to the primary outcome for early intervention with TAVR. However, the task force was had a bit of trouble with this interpretation of this data, because the main primary outcome was driven by those patients that received early TAVR in the control group within the first 6 months. And obviously, that's an event that can't occur in the other group because they already had a TAVR. And that makes the data hard to discern. EVOLVed also, there was not really a big difference between conservative management and early intervention. But we do have the two previous surgical studies, Recovery and Avatar, which showed a benefit for early surgery. So we felt it was safe to say a 2A recommendation would be appropriate for these asymptomatic patients. Then one of the most important changes was the adjustment of the age for TAVI down to 70 from the previous 75. However, there's a new word, as you can see highlighted in red, and that is tricuspid aortic valve stenosis. And this reflects the increasing number of data that are available in low-risk patients between the ages of 70 and 75 from the low-risk trials, but all of those low-risk trials excluded bicuspid aortic valve patients. Therefore, we explicitly said tricuspid aortic valve stenosis more than 80, that TAVI should be recommended. And we also removed the surgical risk score, the STS score, from that recommendation. SAVR continues to be recommended in those patients less than 70 if their surgical risk is low. And we also said that all remaining patients who want to get a biological heart valve should be discussed within a heart team assessment. This figure on the top left just shows the different options that are available. We continue to recommend mechanical valves in patients under 60, but the fact is that most patients, at least in Europe, do not want to have mechanical valves. And the Ross procedure in those centers that have the expertise is really an excellent alternative for patients up to 40 years of age. On the right, you see our summary of the different features that should be taken into consideration when considering SAVR versus TAVI, including age, of course, and lifetime management. Age is the one criteria that we felt the most comfortable with, because it is so easily quantifiable and has a pretty good relationship with life expectancy. But the problem with life expectancy, that would be the best variable if we had it. The problem with life expectancy is it's difficult to calculate. Most clinicians wouldn't take the time to do it. And the data is just not available in many countries, even in Europe, and also varies from region to region within countries. And therefore, lifetime expectancy is a difficult concept, or life expectancy is a difficult concept, and therefore we decided to go with age. So this is the 1C recommendation where we said that lifetime management should also take into consideration this estimated life expectancy. But as I said, it's a difficult thing to quantify. There's also a new 2B recommendation for TAVI for bicuspid aortic valve stenosis patients, but only if they are increased surgical risk and only if the anatomy is suitable for a TAVI. As you know, the results for TAVI in bicuspid aortic valve disease are not quite as good as for tricuspid aortic valve disease. And therefore, we wanted to be a bit conservative on this recommendation. And then we have a 2A recommendation for non-transfemoral TAVI in patients who are unsuitable for surgery and transfemoral access. So whether that's transapical or transcarotid or subclavian access, and that has been upgraded to a 2A based on increasing data on these results, on these procedures. So now switching to primary mitral regurgitation. Surgery remains the procedure of choice for primary mitral regurgitation in symptomatic patients or in asymptomatic patients with LV dysfunction, either a big ventricle or a decreased EF. So those were unchanged, but we do have a new Class 1B recommendation for surgery in asymptomatic patients if they have 3 of the 4 following criteria: atrial fibrillation, pulmonary hypertension, left atrial dilatation, or concomitant tricuspid regurgitation. And this recommendation is based on the very, very good results for mitral valve surgery for primary mitral regurgitation with extremely low mortality rates of about 1%. And this paper, which was recently published, showing this clear differentiation for the patients with 3 or more of those secondary factors that I listed before, having the worst long-term survival. So we want to intervene in patients, and this is a general theme throughout the valvular disease guidelines. We want to intervene in patients earlier in their disease process before their post-intervention life expectancy starts to decrease, before it's too late. Now, we also added a new recommendation for minimal invasive mitral valve surgery in centers that have experience. And this is based on a randomized trial from the UK, where they showed decreased length of stay and accelerated recovery. And then also for primary mitral regurgitation patients, we have a new recommendation for TEER in those patients who are at high surgical risk and are anatomically suitable for TEER. And there's a long table in the document showing which patients are anatomically suitable and which ones are not. So this is summarized in this figure here, showing the different decisions along the pathways when determining which type of intervention is the best for these patients, with an increasing stress being placed on mitral valve surgery and TEER under the appropriate circumstances. As Dr. Nair already alluded to, one very new thing in this guidelines is the differentiation between atrial secondary mitral regurgitation and ventricular secondary mitral regurgitation. In the past, there were multiple different definitions of atrial secondary MR, and we've come up with what we think is a very good definition that hopefully will become the standard from this point on. And it was important to differentiate between these two types of secondary mitral regurgitation because they have much different prognostic trajectories, with the atrial SMR patients doing much better, mostly because of their preserved left ventricular function. So talking about ventricular secondary mitral regurgitation, we have a revised recommendation for TEER. We've increased it up to a 1A recommendation based on another randomized trial, not just COAPT and MITRA-FR, but also the ReShape HF2 trial, which was recently published, and the meta-analysis thereafter showing that TEER in these patients leads to decreased heart failure hospitalization, and improved quality of life if they meet the strict criteria for those trials. And these are some of the anatomic and clinical criteria that patients had to meet in order to qualify for those trials. So I think we have to be careful and remember that there are these inclusion and exclusion criteria when trying to decide if TEER is the right treatment for ventricular secondary MR. The COAPT 5-year data you're already all very aware of, showing marked reductions in hospitalizations for heart failure, as well as in mortality in those patients that received TEER. The selection criteria, the anatomic selection criteria in particular, were quite strict for the COAPT trial, but also the ReShape HF2 trial confirmed a benefit of TEER with regards to hospitalization for heart failure or death, mostly driven by hospitalization for heart failure, as you see in the top right, but also resulting in better quality of life scores, as you can see in the bottom right. And this is the meta-analysis that I alluded to on these 3 trials, showing an improvement in hospitalization for heart failure and an improvement in quality of life. So moving to atrial secondary mitral regurgitation, we have 2 new recommendations. One is for 2A recommendation for surgery. The reason is that there are some very good studies showing some good results with surgery, because surgery addresses the marked dilatation of the annulus of the mitral and oftentimes the tricuspid valve. Both can be treated at the same procedure, as well as an ablation procedure can be done, and the left atrial appendage can also be closed. So these were the reasons why we thought surgery should have a slightly higher recommendation, 2A, than TEER as a 2B, but is also probably better than medical therapy in patients that have significant symptoms. And this is the REVEAL AFMR registry from Japan, with a very large number of patients, over 1,000 patients, of which 113 underwent surgery. And you see with propensity matching, there was actually a statistically significant better survival for surgery, even though these were tended to be a bit sicker patients. And then the TEER for atrial SMR data from registries also shows good results with atrial MR. However, one of the problems with TEER is that you can end up with mitral stenosis, and you see in the top right corner, if the gradient is more than 5, that results in worse outcomes over time. So this is the figure that we came up with for secondary mitral regurgitation, similar to the previous figure, but with just some fine tuning. As far as mitral stenosis goes, none of these recommendations were changed from the 2021 guidelines. There was no new data or studies that made the task force want to change these recommendations. Percutaneous mitral commissurotomy remains the treatment of choice in symptomatic patients or in high-risk asymptomatic patients. Surgery, of course, is also a good option for those patients that are not anatomic candidates for commissurotomy. And then we also have a new recommendation, a 2B, for transcatheter mitral valve intervention, so replacement, for symptomatic patients who have severe MAC and mitral stenosis. This is based on the mostly registry data using the transapical but now transfemoral mitral valve replacement device. And tricuspid regurgitation is also obviously a lesion that we spent a lot of time looking at. There's been a lot of new information in this area. First of all, we recommend it as a 1C, so it's just expert opinion only. But we felt because these can be very complex patients, that they should be assessed by a multidisciplinary heart team before intervening, either surgically or interventionally, on these patients because they can be very complex and very high risk. We have for surgery slightly refined the previous version, saying that if a patient has a reason for left-sided valvular surgery, usually it's the mitral valve, and they have moderate TR, that's a 2A recommendation to do a tricuspid valve repair, and a 2B if they have mild TR along with annular dilatation. With regards to patients that do not require left-sided heart valve surgery, so isolated tricuspid valve problems, transcatheter treatment is now a 2A recommendation, level of evidence A, because of multiple RCTs and large registries, showing that it results in better quality of life and RV remodeling in these high-risk patients, as long as they don't have a severe RV dysfunction or severe pulmonary hypertension. And this is one of the studies that this was based on. As I'm sure you all know, this study, the TRISCEND study, which showed a statistically significant improvement in the composite endpoint of death or tricuspid valve surgery or hospitalization for heart failure, and an improvement in quality of life KCCQ score of more than 15, as well as the TRI-FR randomized study, which also showed a significant improvement in those patients randomized to tricuspid TEER versus optimal medical therapy alone, resulting in better symptom improvement and freedom from hospitalization in those patients that were intervened. And we also have the TRISCEND, the previous one I showed, the first one I showed was TRILUMINATE, and this is then TRISCEND, which is for tricuspid valve replacement, where also patients were shown to have better quality of life scores and a little bit longer 6-minute walking distance in those patients that received tricuspid valve replacement percutaneously. However, there's many criteria to be taken into consideration for these very complex patients, including how much restriction the leaflets there are, if there's a CIED, a pacemaker present, et cetera, et cetera, et cetera. And therefore, we recommend that the involvement of a expert multidisciplinary heart team for the assessment of these patients. In the chapter on mixed and multiple valvular heart disease, we significantly expanded that, including a new table showing sort of echocardiography tips and tricks to deal with the sometimes complex mixed valve lesions and the effect of one valve lesion on the other for echocardiographic assessment. But we also have 2 new intervention recommendations, the first being a 1B for patients with symptoms and mixed moderate stenosis and regurgitation, or even in asymptomatic patients with mixed moderate stenosis and regurgitation if the EF is less than 50% and no other attributable causes can be found. There's also a very nice section on prosthetic valve dysfunction of aortic and mitral bioprosthetic heart valves that I would suggest that you take the time to read in detail when you're looking at these types of patients and the management of these patients. As far as prosthetic valves for anticoagulation is concerned, we said that a mechanical heart valve should be considered in those patients that have long life expectancy and have no contraindications to long-term oral anticoagulation. We also have new recommendations for adjusting the type of INR or the INR target based on the type and position of the mechanical heart valve and the patient's risk factors. And for the first time that I know of, there's also a patient-centered 1A recommendation, and that is for education in order to improve the quality of their oral anticoagulation, especially if they're using the home monitoring devices. We also have a new 1A recommendation for those patients that need minor procedures. after mechanical heart valves. So somebody needs some dental work done, or a minor dermatologic procedure. We said, don't stop the anticoagulation treatment, the vitamin K antagonists. They should continue to take it right up to the time of the procedure, as long as the procedure has a low risk of bleeding. And then there's a new 3B recommendation against dual antiplatelet therapy after TAVI because of multiple randomized trials demonstrating this. And this is a figure that we've revised and I think also significantly improved compared to the 2021 guidelines. And I really suggest that you look at this figure when you're trying to determine what to do with your patient's anticoagulation after heart valve intervention. And there's also this table looking at what to do if these patients need a procedure afterwards, depending on what kind of mechanical heart valve they have, where it's located in the aortic or the mitral or tricuspid position, if it's going to be a low-risk procedure for bleeding or a high-risk procedure for bleeding, if you need to do heparin bridging or not. These are all very carefully described in this chapter, and I would highly suggest you looking at this for these sometimes difficult questions for our patients. So that was a lot of information, and I believe we'll probably have quite a few questions based on that. So in conclusion, we have 28 new recommendations. We believe that as the task force, that these are very patient-centered recommendations. In every one of the figures, you always see the patient in the middle with the doctor. The heart team makes their evaluation of the patient's information and makes a recommendation, but then speaks with the patient and takes into consideration their preference and goals before coming up with the shared treatment decision. We believe the document is pragmatic and easily readable. We have an emphasis on the disease mechanism and the importance of determining that, usually by echo, but also with other advanced imaging techniques in order to determine what the best approach is for the patient. We reinforce the importance of the heart team and the heart valve center for complex procedures. We have new recommendations for asymptomatic patients, kind of making a general shift towards trying to intervene earlier in the disease process before it's too late. And we have these new and extended sections for management of specific subpopulations. I would highly encourage you to look at the ESC website, where you can download the app, or the pocket guidelines also are available online, as well as the presentations. Please scan this QR code if you are wanting to obtain that information. There's also a new chat bot from ESC where you can type in, for example, I have a 65-year-old patient without symptoms but has atrial fibrillation and mitral regurgitation and doesn't want to take Coumadin. What should I do? And it will say to you, we suggest this based on this table and this figure of this ESC guidelines. I think it's a really very interesting tool, and I would highly encourage you to take a look at it. Thank you very much for your time and attention.
Thank you, Professor Berger. I mean, everybody would agree that it was an extensive coverage and so much of new learning. I think you'll all agree what I said, what we all said in the beginning, that I think no other area has shown so much of new recommendation, 28 new recommendations, right? And so many new revisions are coming. So I think we need to go through it, and please download. You saw that pocketbook free. Please download and go through it. So much of new data. I think we have some few questions coming up. So by the time more questions come up, relevant stuff, this is something where you have already answered. But let us go one by one because we have about 15-20 minutes left with us. I'll start with the aortic valve disease. So, we have seen a lot of change in indication of TAVI in this new guideline. The age has come down to 70, and recommendations have changed. People have become more liberal today. And today patients are coming and asking, when we tell them that you have aortic valve disease, can I have TAVI? And you have shown, for example, that how there is outcome difference between bicuspid aortic valve and trileaflet aortic valve. So anybody above 70 trileaflet aortic valve, a clear recommendation for TAVI. So Professor Berger, for the benefit of all the listeners, could you tell us the kind of patient that you have in mind who is the ideal person for TAVI in a background of a significant aortic valve disease?
Well, the ideal patient has, first of all, very good transfemoral access, because the non-transfemoral access data is clearly, worse associated with worse outcomes than transfemoral. The exact and anatomic characteristics of the root also need to be taken into consideration. How extensive the calcification is, if there's extension of the calcification into the subvalvular area, that will increase the risk of a paravalvular leak or even annular rupture. The distance to the coronary arteries, those are all sort of the known factors that the TAVI specialists take into consideration. So you want somebody with suitable anatomy and suitable access, but obviously the durability is still not 100% answered. We've been using some of the surgical valves that we still implant for 40 years. The Paramount valve, for example, we have very long data on that. We know exactly what the durability is. And because most of the early TAVI trials were done in elderly, very high-risk patients, most of them are dead now, and we don't know 100% for sure what the durability looks like. Having said that, there's no strong signal showing that TAVI durability is worse than SAVR. And the low-risk trials are now starting to get to that length of time of follow-up where we will be able to have a reasonable number of patients to make a good estimate of how good the durability is, because the number of patients that survived in the intermediate to high risk, they just is too small at 10 years. So the 7-year Partner 3 data, for example, will be presented at the upcoming TCT meeting in October. We'll have a better look at what the durability is. Notion has 10-year data that's already been published, but the average age for Notion was also quite high, and therefore most of those patients are dead, and therefore it's hard for us to get good estimates there. So that's a long talk, but basically I would say we had to come up with an age somewhere, and 70 seemed to be the most reasonable cutoff. There's going to be exceptions. There's going to be 75-year-olds who are extremely fit, and you might be concerned if you do a TAVI now that then you need to do a SAVR post-TAVI in 10 years from now when they're 85 years old. And maybe in that patient, it's better to do a SAVR now and then a TAVI valve-in-valve in the future. And the younger patients under 70, though, we still just don't know, and we would still therefore recommend surgery.
Yeah, excellent. We have one question from a senior cardiologist from Trivandrum, the same city, Dr. Prakash Nair. He asked that after TAVI, what is the new ESA recommendation for antiplatelet drugs?
Yeah, so just aspirin. So based on a couple of different randomized trials, adding the second antiplatelet medication just led to increased bleeding complications without any significant clinical benefit. And therefore, we came up with this class 3 recommendation against dual platelet therapy in these patients. So just aspirin.
And that would be how long?
Well, a minimum of 12 months. After 12 months, there's really not much data. And therefore, we sort of shied away from taking a very hard stance on what happens after 12 months. We do know that TAVI is more susceptible to leaflet thrombosis, although it's mostly subclinical, so the so-called HALT lesions. We know that it's more prevalent after TAVI than it is after SAVR. What exactly those HALT lesions mean clinically for the patient, we don't know, but there are some signals now in the low-risk trials that stroke seems to be increasing steadily in the TAVI patients, and therefore then this may be related to HALT. So I would be reluctant to stop the aspirin, to be honest. I would want them on some anticoagulation.
Antiplatelets at least, yeah.
Antiplatelet therapy, yeah.
We see overall progressive takeover of the anticoagulation arena by the NOACs, right? Accepting, even in the background of valve disease. So, for example, the edoxaban trials have shown that apart from moderate to severe mitral valve stenosis, in native valve disease, NOACs are good enough, right? So, do you make a choice between the available NOACs? Because when we look into the data, most of the valve disease data is from edoxaban.
Yeah, this is an area that also needs a lot more data. So we have mechanical valve patients are the exception, right? There's NOACs are not recommended in those patients because of the randomized trial showing increased thrombosis rates. So then whether or not you want to use a NOAC for atrial fibrillation, for example, that's fine, but which one exactly, I would have to defer to a specialist in that area. But the after biologic valve replacement or valve repair, there's really very, very little evidence right now. That's the problem. It's the clinical reality is that a lot of patients just get DOACs rather than getting a vitamin K antagonist for the first 3 months after the procedure. That happens a lot, but it's unfortunately not based on evidence. We just don't know right now.
Yeah, for example, patients on bioprosthetic valve post-surgery, many patients are still on AFib. Right. Now, normally, if there was a prosthetic valve, bioprosthetic, we would have stopped all anticoagulants. And now this patient is AFib, so they merited DOAC. So they tend to go on DOAC rather than despite being a valve disease, rather than a vitamin K antagonist.
Yeah, so the recommendations for DOACs and mitral stenosis, for example, are very different than those related to post-intervention. So it's an area that's really in flux right now, and where we need a lot more evidence.
Dr. George Tayal, one of our senior most cardiologists in Kerala, he's asking question. His thought is, considering the reality that many patients in India doesn't keep correct INR, is it advisable to implant tissue valves in patients above 65 years age? What would be your thought on that?
We do recommend a tissue valve replacement for the aortic position above 65 and for the mitral position above 70. So I think that's very reasonable. The bleeding complications associated with vitamin K antagonists are also increase markedly the older the patients get. I'm not obviously as aware as you are as how compliant patients are there, but one thing that has been shown in trials done in Europe is that using the home monitoring significantly improves compliance and amount of time within the target zone. And that's why we came up with that 1A recommendation for education on how to use these home monitoring devices.
Home monitoring of INR has not really become popular in India, despite home blood sugar monitoring, home blood pressure monitoring has become pretty popular. but home INR has somehow not picked up. Maybe the cost, I'm not sure, or maybe the technology has not become cheaper here, but that is more popular. So every time the patient need to come to the hospital, and because we are unaware about their cytochrome P450 to C9, and we are unaware about their VKO or C1, we know we have a lot of patients with tremendous fluctuation of INR. One visit it would be 1.6, next it would be 3.2. So, they go on getting different dosage of warfarin, and basically the time in range must be quite low. And that must be the reason why Dr. George Sal asked that what should we prefer a biologic valve in that background. Professor Morgan, in your guideline, did you specifically include a chapter on rheumatic heart disease?
It's mentioned within each of the valvular etiologies separately, but of course in Europe, as you know, it is a uncommon disease entity. But I was interested to hear your comments earlier that degenerative valvular heart disease is now increasing rapidly in India. I guess that's a reflection of the general increase in patient longevity, but also the economics of the healthcare system, resulting in the better and earlier treatment of streptococcal infections when they're younger. So I assume that you're going to also see a complete shift to the diseases that we now see in Europe.
Did you include a chapter on pregnancy and valve disease?
Yes, there is a new chapter on that. It's not a very big chapter because, as you know, there was also simultaneously published at this ESC the guidelines on pregnancy. And they have also a section there on valvular heart disease. So there's information in both of them, and we didn't want to overlap too much.
Yeah, because, we get a lot of, even now we get a lot of pregnant women coming in with rheumatic heart disease, and many of them have significant mitral valve disease. So the question of timing of mitral valvotomy, percutaneous valvotomy, which trimester, radiation exposure, their symptoms progressively increasing is always a challenging scene, and people tend to discuss them. And, similarly, patients of mitral valve disease, a lot of them with moderate mitral stenosis, still continue to be on rate-lowering agents like beta blockers or rate-reducing calcium antagonists to keep them asymptomatic or less symptomatic till they go on to the threshold where they would require a mitral valve replacement or a repair. Many often the rheumatic mitral valve is not really very suitable for repair because we see dense adhesions and pathology in the chordae, in the subvalvular fusions, leading on to actually a valve replacement rather than the percutaneous intervention or even a valve repair.
Yeah, so those are really complex patients, and in our guidelines, we said that before recommending pregnancy in young women that are considering pregnancy that are known to have valvular heart disease, we said you should address the mitral stenosis if the mitral valve area is less than 1.5, even if the patients are asymptomatic. We also said severe aortic stenosis should be addressed. If your patient is not pregnant, I would suggest a young woman with severe AS should get a Ross operation. From my point of view, that's the best option. And we also said for young women with heritable aortic disorders like Marfan or Ehlers-Danlos, that prophylactic surgery should be done if the aorta is more than 45 millimeters. Once they are pregnant, we stated that mild mitral stenosis is usually pretty well tolerated, and a percutaneous commissurotomy is only necessary if the pulmonary pressures go above 50 despite optimal therapy, or if the patient develops heart failure. And aortic stenosis also, if they develop heart failure, then we said, okay, TAVI would be a good option, although there's very little experience with this. It's a good option because you don't need to use cardiopulmonary bypass, which, as you know, is associated with a high rate of fetal loss. But as I said, TAVI in pregnant women is a very small, just basically case reports at this time.
One question asked in the chat box is, what are the new recommendations of beta blockers and the ESC guideline relating to valve disease? Probably they're trying to say about mitral stenosis, as well as probably, like Marfan syndrome with aortic dilatation.
Yeah, for any syndromic aortic dilatation, definitely beta blockers are indicated. For those patients with mitral stenosis and symptoms, also definitely. The other common indication, at least in Europe, is with concomitant coronary artery disease, of course. But as you know, and we talked about this a bit before offline, medical therapy for most valvular heart disease is mostly just temporizing until the symptoms can be addressed with an intervention.
Yeah, and for the general listeners here, understand that many of the regurgitant lesions, if you give beta blocker and slow down, the diastole prolongs and your regurgitation actually might be increasing in severity. Professor Berger, one last area, we are at time, but then one area that was really surprising in your guidelines that you showed was equating the dobutamine stress with an calcium score, right? That looked so interesting because we were not sure as to where to place them in a low flow, low gradient aortic stenosis, but you showed them they're equal weightage being given.
Yeah, basically whether or not they have contractile reserve, as demonstrated by dobutamine stress echocardiography, has a relatively small impact on the benefit of aortic valve intervention, surprisingly. So basically, you can do dobutamine stress echocardiography just to see that you have a increase in the gradient and the decrease in the valve area under stress. But there's been a pretty clear shift, at least in Europe, just to go ahead and get the cardiac CT and then to quantify the calcium score. And if the calcium score is elevated, then that is, from our point of view, absolutely enough information to say that the patient has severe aortic stenosis. So if it's more than 1,200 angstrom units for females or more than 2,000 for males, then this is severe aortic stenosis and needs to be treated.
Yeah, very interesting because one is an anatomy where you're looking at the calcium and the other is physiology where you're trying to see whether the contractile reserve improves with dobutamine. And both of them showing, in fact, like you say, a calcium score showing a better outcome, I mean, more important outcome determinant rather than a physiology, tells us that probably we should not waste time doing the dobutamine stress and straight away go for a calcium score. It's far more easier, far more.
And don't forget, dobutamine stress echocardiography is also it's more difficult and it's also subject to interpretation. It's not as quantitatable as cardiac CT.
So I think there are no more questions, or the rest of the questions are unrelated to today's topic, so we'll skip them. So I think with that, I've learned a lot. I have learned a lot. We have learned a lot about the new guidelines on aortic valve disease, interventions, TAVI, how the guidelines have changed over the years, and aortic regurgitation is coming into the purview of TAVI, how mitral interventions change, dividing them into ventricular, secondary ones, ventricular and atrial, and how the interventions differ. We have talked about almost everything relating to tricuspid valve intervention. So very interesting. And you have shown all the data. So I think before we finish, Professor Berger, would you want to tell our listeners a one-line take-home message, apart from the fact that they should all download the pocket guideline and read it thoroughly?
I guess my one take-home message would be don't wait until the patient is too far in their disease process. If there's signs of cardiac damage, then please start planning for the appropriate intervention. And the last thing I would just say is, thank you for the invitation. I've been to India many times. I'm always fascinated at how fast it's progressing and changing and growing, and won't be long until we're all learning from you. And I've been there many times for the conferences, and we'll be going to the Mumbai conference for cardiac surgery in February. So I always look forward to these interactions and continue to look forward to them in the future.
Thank you, sir. And I hand over to Jusna for the word of thanks.
Yes, thank you so much. So very good evening, everyone. As we come to the close of today's enlightening webinar, it's my honor to deliver the vote of thanks on behalf of Aristo's team. First and foremost, my heartfelt gratitude goes to Dr. Michael Borger, our distinguished speaker for today. Thank you, Doctor, for sharing your valuable insights. Your presentation was not only thought-provoking, but also incredibly relevant and engaging. We are truly privileged that we have benefited from your expertise. We are equally thankful to Dr. Tiny Nair, who so graciously guided us through the entire session. Your thoughtful moderation ensured a smooth flow, encouraged meaningful discussion, and brought out the best from both the speaker and our participants. Thank you for your support and presence throughout the session. To our wonderful audience, thank you for taking time for us to join. Your participation, thoughtful questions, and attentiveness in the webinar has made this a collaborative success. Thank you to all of you. Thank you, Team Centrix, for keeping us through the entire session. Right. Once again, our deepest thanks to Dr. Michael Borger, Dr. Tiny Nair, and each one of you here today. We look forward to have interact with you in future also. Thank you. Have a great night.
Good night.
Good night, sir. Good night.
Thank you.